topic. I just finished telling you how much I really like talking about this topic. And it's for a couple of reasons. One, I think it's really interesting. And I hope that you guys walk away from this today also feeling like you've learned something interesting. But two, I just don't think it gets enough airtime in the realm of discussions that we tend to have around perinatal mental illness. Um, there's a lot to be said here as it relates to this overall and overarching topic of safety in the perinatal period. These are people who, with bipolar disorder, for example, that are very, very vulnerable to mental health changes during this time frame. And those vulnerabilities extend to really significant vulnerabilities to safety concerns and psychiatric crisis, which is perinatal psychosis. So these topics go beautifully together for that reason and others that we'll discuss here shortly. And I think that we can make a pretty big impact just learning more and being able to like address these issues a little bit better. So let's talk about what our objectives are today. So, of course, I do want you all to walk away being able to recognize the signs and symptoms of bipolar disorder and perinatal psychosis. And I also want you to be able to recognize the specific safety concerns that arise with both of these things. And then I want us to be able to tie that all together and be able to really have a meaningful discussion about what are the implications for the moms and babies that we care for, right? How do all of these things that we know now after this lecture about bipolar illness and psychosis change either what we're doing for clinical practice or change the way that we think about the systems that we have set up for caring for moms, especially, but also their babies, right? And I think that my overarching hope is that you take some of this knowledge and are able to kind of bring it back to the systems that you work in and make change where change can happen. A couple of things that we're not going to do today that I want to kind of remind you of from previous, not episodes, lectures in the series. We're not going to talk in depth about sleep, although if you haven't watched that presentation, please go back and watch. That was the first presentation in the series. There are huge implications for sleep in the realm of bipolar disorder and perinatal psychosis, and I'll talk to you about why it's so important, but we're not going to have an in-depth discussion about how you can use management of sleep to prevent some of these concerns from arising. We're also, unfortunately, not going to dive in depth on medications today. There's other things that are far more important. And when it comes to management of bipolar disorder and psychosis, it has to be done with a psychiatric professional who will already know about the medications that are needed. I will touch briefly on a couple of things like why the meds we use for other conditions, for example, aren't great for this population, but we're not going to talk in depth about those medications. And I think the other piece that we're missing is a survivor perspective. I've been really fortunate to give presentations on this topic with survivors, and their perspective really, really lends a perspective that I think is really important as far as like how significant these issues really are for the people that experience them. I will be addressing this really from the clinical standpoint, really from a professional standpoint, but I want you to be aware of what you might be missing out on. And there are organizations like Cherished Mom that you can look into. There's a postpartum psychosis awareness day every May. And that's a really great place to get that perspective so that you kind of understand a little bit more about like what it might be like for patients who are experiencing this. Okay, let's dive in. So, a couple of things. First, we're going to start with bipolar disorder. And the reason we're starting with bipolar disorder is, as we'll talk about later, perinatal psychosis is very often a direct result of bipolar disorder. So I need you to know about bipolar disorder before we dive into that topic. And also because this is potentially more common, for example, than like the actual progression to psychosis, which we're going to discuss in just a moment. What is bipolar disorder? Bipolar disorder is an illness with two poles, hence its name, and those poles are depression and mania. So episodes of depression and episodes of mania occur in the context of somebody with bipolar disorder. You have to have an episode of mania to qualify, or hypomania, which is just like a less severe version of mania, to qualify for a diagnosis of bipolar disorder. You don't technically have technically have to have a diagnosis of an episode of depression, but most women and most people who are experiencing these hormonal changes actually tend to have more depressive episodes than they tend to have manic episodes. So just keep that in mind. You do have to have at least mania, but very often there's both, and very often for women at least, there's more depression than there is mania. This is also, I want you to realize, a very biological illness. And what I mean when I say that is this is not like a clinical definition of what a biological mental illness is, for example. But when I say that, I mean that it's very chemical, very biological. There's like very clearly a pathophysiology occurring in the brain that is leading to these symptoms. And I'll compare that to, for example, something that is not very biological, although we know that mental illnesses across the board have biological components, right? There's like chemical malfunctions that happen that contribute to symptoms, for example. But the illness that I'll compare it to is post-traumatic stress disorder, right? Where there might be like a genetic or biological vulnerability that somebody has that predisposes them to develop PTSD in the context of a traumatic event. They have to have a traumatic event, right? They have to have that trauma piece in order to develop that disorder. Not the case for something like bipolar disorder. Yes, certain stressors, certain influences, like for example, hormonal changes associated with puberty, can bring about the start of the illness, but it's very much like a biological process that drives the illness in particular. And why that matters for our purposes is that when we have illnesses that have these strong biological or chemical components, whatever you want to call it, they tend to be really hormonally sensitive. So for our population, moms, people who are in the perinatal period, going through pregnancy and postpartum, and experiencing these dramatic hormone changes that are associated with that life stage, their illness is extremely vulnerable to get worse, whether that means just a worsening of like the symptoms of their illness, a worsening of the overall course, like the mania or depression comes more often, um, um, or just like predisposing them for like worse long-term outcomes. Like they then have a more severe version of this illness, you know, for the rest of their lives, that kind of thing. So it's really important to recognize that like this is an extremely vulnerable population, and it's specifically related to the fact that it's pretty biological and there's a lot of hormone sensitivity. That is, I think, evidenced by the stats here. Okay, so these are some stats that I think are important to kind of recognize. First, these folks have a very, very, very high rate of recurrence, exacerbation, or worsening of symptoms during pregnancy and in the postpartum. Even people who are considered to be stable prior to pregnancy have a very high rate, half or more probably, of relapse or exacerbation during pregnancy. I think if we could look at data and compare people who are medicated and remain, you know, stabilized on psychiatric medications compared to those that don't, you would see for sure lower rates than these 70 and 71%, but it would still be pretty high. And people who work in this population know that this is a pretty fragile group to work with, and they require a lot of close monitoring and close following, even when you have meds, medication and treatment plans that are working really well for them prior to pregnancy. Along the lines of this, half of people have their first diagnosis, half of women specifically, from the statistical standpoint here, have their first diagnosis of bipolar disorder during the perinatal period. That's not because they've all of a sudden developed bipolar disorder because they're pregnant or postpartum. Typically, they've had evidence, like they've had hypomanic or manic episodes prior, but usually because of the hormonal impact, their illness gets worse. And so they present to care because it's finally bad enough that they need help, right? So where they may have had only hypomanic episodes prior, maybe they're having full manic episodes now, where maybe they were having, you know, depressive or manic episodes, you know, only once in every few months or in a great while. Maybe they're having them much more often now, right? Or the symptoms themselves are just more severe. Similarly, it's important to remember that people are very often misdiagnosed with what I'll refer to as unipolar depression. that is basically your straight, like major depressive disorder. When I say unipolar depression, um, that's going to help differentiate that from when somebody has a bipolar illness but has depression with that. And that's because similar reasons, like we don't see the mania, it's not as bad, right? As maybe the depression, or the person doesn't come to seek care until they're in a depressed state. And also, even in this context with patients who may be getting worse because of hormonal changes of pregnancy, it's pretty common that the episodes that we see early in pregnancy are depressed or mixed episodes. So again, we're not seeing that like clear mania or hypomania to be able to diagnose them appropriately. And this is all to say, like, um, people who come into care with like these vulnerabilities, we might not recognize them as being that vulnerable, right? Because we might not have identified them as having these conditions ahead of time. And that when somebody is experiencing these distinct, like, mental health changes associated with pregnancy, it's a pretty good idea to have them evaluated by a mental health professional who can actually go in and really look at the history and help them identify if there's been mania in the past and if we can get to the correct diagnosis. All right. So let's talk about symptoms. Again, bipolar disorder consists of two mood states, and the first one we'll talk about is the manic state, or the state of mania. Mania is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and persistently goal-directed behavior or energy. People in this distinct period of persistently elevated mood and goal-directed behavior or energy also tend to experience things like increased self-esteem, decreased need for sleep, being more talkative or more pressured to talk than usual, having a flight of ideas or racing thoughts, being more easily distractible, increased in goal-directed activities, or even excessive involvement in activities that are risky, like risky behavior. Things like really significantly increase in spending, sexual promiscuity, and even involvement in drugs and alcohol and things like that. And that would be like things that are out of character for the person. Now, one of the things I want to highlight with the perinatal population is that mania, again, to remind you, can be a full manic episode, which would include a lot of these symptoms, and they would be very severe or more severe. They would also last for longer periods of time. Or it can be hypomanic, where these symptoms are more subtle or less severe, and they last for shorter periods of time. For moms who are pregnant or postpartum, I cannot tell you how many times I have had patients come into care and they are having hypomania, but other people around them and they themselves are chalking it up to, for example, nesting. Okay. Let's look at how this could look like nesting. So you have somebody who has maybe their mood is more irritable, right? With this distinct period of abnormally altered mood. It could be elevated, right? But it could just be irritable. Maybe their mood is more irritable. That's pretty common. They're not having the elevation or expansiveness of full mania. And so they're pregnant, right? And so people say, oh, they're just irritable because, they're uncomfortable, they're pregnant, they're not sleeping as much. People tend to like always want to chalk up anytime a woman is experiencing hormone changes to like, that's what they're just hormonal, right? They're irritable, right? They might not be sleeping as much, right? So this is the mom that might be awake at 3 a.m, painting the nursery, building some bookshelves, because she wants to and saw it on Pinterest, right? Doing all kinds of other stuff around the house. But they're just nesting, right? But obviously mom is not sleeping because she's doing that kind of stuff in the middle of the night. That all that activity, right? That building the bookshelves, painting the nursery is that goal-directed activity. Mom is probably more focused on that. She's probably getting it done a lot faster. She's probably being more productive than she would normally be. And that's again being chalked up to this whole nesting process. And she's also at the same time bought all these supplies. She's additionally gone beyond that and she's bought a bunch of stuff for the baby, a bunch of organizational things, but this is all just nesting, right? That's how this gets chalked up to that. So we have a lot of people who, I think because of the way we perceive, normal experiences during pregnancy and postpartum, who may be getting missed again because we're perceiving these abnormal changes as really normal changes of pregnancy, for example. Similarly, postpartum, I see this very frequently. People are often celebrated for experiencing hypomania postpartum, right? Because they're like doing fine on 3 hours of sleep when the baby's not sleeping, and they're also keeping the house clean and they're getting everything else done, and they seem great, right? Their mood is elevated, so they don't seem depressed. Maybe they're a little bit irritable, but again, they're postpartum, right? So they're hormonal. And I point all this out just so that you know that these things can be quite subtle and they can still be a problem. And even if it's just hypomania, it still is within the context of this bigger problem, which is bipolar disorder, and makes that person very vulnerable then to worsening of symptoms and safety concerns that we are going to talk about here shortly. Depressive symptoms, I'm not going to go through all these. These are the same symptoms as for depression. And if you go back in the series, you can listen to the talks on specifically postpartum depression or perinatal depression, and go through all these symptoms specifically. The thing I want to point out is how this doesn't always look like depression for perinatal moms. And in general, we have this idea, I think, culturally, what depression looks like. People often think of people who are crying and sad. And really, depression very often looks like emptiness, lack of emotion, lack of joy, flatness of mood. People who are very tired, people who are not experiencing a lot of joy in things, and maybe even people who are maybe feeling anxious. This is the psychomotor agitation part of things. So it's just important to remember that the way we perceive mental health concerns doesn't always show up in how the person presents to us. And keeping in mind that depression can look like that can help a lot with identifying somebody who's experiencing those symptoms. Perhaps a little bit more importantly is being able to identify when somebody has these soft signs, we call them, of bipolar depression. So again, these symptoms here are the same symptoms as show up in a unipolar depression diagnosis, right? So that would be major depressive disorder, for example. They're the same symptoms, but this person also then has episodes of mania. So how do we distinguish that? It can be very difficult, but there are soft signs, and they're captured, most of them, a lot of them are captured in this mnemonic called whiplashed. So somebody who is experiencing a bipolar depression would typically be less likely to respond well to antidepressants. They would be wired or worse on antidepressants, or the antidepressants may work only for a little bit, or and then stop working, or actually maybe induce a little bit of mania. So they get a lot better way too quick, kind of thing. Hypomania, there might be elements of that hypomania that you can see in somebody who's experiencing even a depressive episode. We call this like a mixed condition, but you can see some of those elements sometimes in the depressed person. The depressed person is more likely to have these atypical features of depression. They're more likely to have really prominent irritability. They're more likely to have increases in appetite and sleep, as compared to somebody with unipolar depression, where they're more likely to be have lower appetites and decreased sleep. They are likely to have psychomotor retardation. So they're likely to be the people who are in bed and can't get up and do anything versus people with unipolar depression who are less likely to have that. They are very often, again, remember this genetic or biological component, likely to have loaded family histories. What does that mean? That means basically not that people in their families necessarily all have a bunch of bipolar disorder, but they may have other mental illnesses, but there's a lot of people in the family. There's a lot of genetic load there. We also tend to see very abrupt onset or ending of depressive episodes. So with unipolar depression, people are more likely to have, like they slowly get more depressed and they slowly get better out of their depressive episodes, versus bipolar depression tends to be pretty distinct. Like people will even say sometimes like, I wasn't depressed yesterday and I'm depressed today. So days or weeks maybe where their depression just comes on very quickly. And then same thing with the ending of the depression, they'll say all of a sudden I just didn't feel depressed anymore. We see a hormonal vulnerability. So people with bipolar depression are more likely to have episodes in the perinatal period, postpartum in particular. And they are also more vulnerable to seasonal changes. So these are the folks that tend to get pretty distinct seasonal affective illnesses, seasonal affective disorder, and sometimes hypomania in the spring. They tend to be depressed earlier. Okay. So we talked about this already. Like the onset tends to be earlier, like at least by puberty, sometimes even before. And they also tend to be more vulnerable to experiencing psychotic features in their depression. Where are we on time? We're good. Okay. Um, that leads us in to psychosis. So perinatal psychosis, as we'll discuss, is kind of its own condition, and I'll talk about that in a second. But what I want you to understand before that is psychosis simply in the bigger picture of mental health concerns is a mental state where the person is disconnected from their reality. Okay. So this can exist across a number of mental health concerns. Psychosis can exist in the context of a mood episode. So somebody who's very, very depressed can experience psychosis. Somebody who's more severely manic can experience psychosis. It can also exist as a prominent feature of a psychotic disorder like schizophrenia. It can exist in other like more medical clinical states like delirium. There's all kinds of ways that psychosis can show up, but psychosis itself is just a mental state, and it can happen for a lot of different reasons. Okay. For our purposes, psychosis, sorry, I'll go back. Psychosis tends to show up most for people with bipolar disorder in the perinatal period in the context of mania. There absolutely are many cases of of perinatal psychosis or postpartum psychosis that show up when the person is experiencing a depressed episode, but most of the true perinatal psychosis, postpartum psychosis shows up when somebody is experiencing mania. Very often, postpartum psychosis, and I'm going to kind of switch my terminology now because when we get into statistics, that's usually what we're talking about. There's not as much data on psychosis that happens during pregnancy. A lot more of the research has been done, and almost all the statistics that you'll see are related to postpartum psychosis specifically. So when we talk about postpartum psychosis, there's often a tendency of people who are discussing this topic to refer to it as rare. A lot of the survivors that I've worked with have a problem with that, and I agree with them. I think that when we talk about this as being rare, I think we minimize the potential risk, and also I think we're missing the actual severity and the actual incidence. The most common statistic you're going to see is that it occurs about 1 to 2 per thousand, so like 1 in 500. That depends a lot on the population that you're seeing. Okay, so for example, me and my population, I do reproductive psychiatry. I work with almost exclusively moms or people that are pregnant or postpartum, and who also have typically other vulnerabilities, like they have pre-existing mental health conditions, things like that. This incidence is way higher. I don't know what the statistic is because that research hasn't been done, but I can tell you for sure, far more than 1 in 500 or 1 in 1,000. Similarly, you may be working in settings where the incidence of this is higher because of the vulnerabilities of the population that you work with. If you're working with, for example, primarily low income families, we know that mental health concerns in those families are typically much higher. So that population is more vulnerable. So probably the incidence of this is higher as well. And that's all just to say, like, I think one of the reasons this doesn't get as much consideration is because it's perceived as rare. But there's a lot that we're missing out on in the policies that we kind of enact in our systems to be able to prevent some of the safety concerns that arise with this. So if you guys are going to go away from here, keep that in mind and maybe make some policy changes if you can. Some other fast facts that I want you to know are that half of moms who experience postpartum psychosis are first-time moms. This is their first pregnancy with no previous psychiatric hospitalizations. That is not to say they don't have pre-existing mental health conditions, but these are not people that you would necessarily look at and think they are particularly vulnerable to something as severe or extreme as postpartum psychosis. These may be people that on the surface don't look all that vulnerable because they haven't had more serious mental health treatment like a hospitalization. Some people do have a single isolated episode of postpartum psychosis. That's the goal, obviously, is that we like get them treatment and then we don't let it happen again kind of thing. But more often than not, especially without treatment, in fact, without treatment, it's almost guaranteed to reoccur. But especially without treatment, postpartum psychosis recurs with each subsequent birth. And also can occur, it's important to remember that if there's a loss, the later the term, the loss, miscarriage, or even a termination, that people are vulnerable with those situations as well. And usually if it recurs, it's going to be worse. There's some really good case studies of real life people for whom this has happened to. Andrea Yates is probably the most prominent. If you look at her case history and you really read through her information, it was exactly like this. She had multiple pregnancies with worsening mental health issues and worsening psychosis with each birth. Where psychosis and bipolar disorder overlap the most is that the vast majority, 86% at least, this number kind of changes depending on what you look at, but I haven't seen a number less than 86%, have bipolar disorder who experience postpartum psychosis. So the people who are at greatest risk of this are people with bipolar illness. And then very importantly, these are the people that are truly the most vulnerable to the safety concerns that we are worried about in the perinatal period. It is estimated that about 5% of people with perinatal psychosis will die by suicide and about 4% will commit infanticide. That is a truly like, when we look at these numbers, that is truly an estimation. There's a lot of problems with getting data on that kind of stuff, but that's an estimation. And there's people that argue that those numbers are quite a bit higher. This is to say, people who experience mental health concerns across the perinatal period absolutely are vulnerable to especially things like suicide. But these are the people that are most especially vulnerable, and psychosis in particular puts people at extremely high risk to follow through on these safety concerns like suicide and homicide. Okay, so some risk factors. The risk factor I want you to walk away with, if nothing else, is remembering that the biggest risk factor is a first-time pregnancy with a previous family or personal history of bipolar disorder. That is the single most important risk factor. It is not necessarily that somebody has had psychosis in the past. It is not really anything else about their personal or family history, just simply that it's their first time pregnant and they have a personal or family history of bipolar illness. Other things to keep in mind are obviously people who have pre-existing mental health conditions, like otherwise are potentially more at risk. People who don't maintain on their medications, they're more at risk because their symptoms and their illness is left untreated. And then very importantly, for people who are at risk of postpartum psychosis, disrupted sleep near the time of delivery is an extremely important risk factor. In fact, there's very good evidence that preventing sleep loss near delivery can actually avert an episode of psychosis. So that's huge. And we'll talk about that a little later when we talk about considerations. While psychosis is a mental state that can exist for a number of reasons across different mental health concerns, there is actually some evidence that postpartum psychosis or perinatal psychosis is sort of its own unique thing. Dr. Spinelli is a researcher and clinician in the field that has really been kind of a champion of this illness and of researching and understanding it better. And she's developed the symptom triad that we now think about when we think about perinatal psychosis. It includes mood symptoms. So those would be the symptoms of mania or depression that we've discussed, psychotic symptoms, which we're about to discuss, and cognitive disorganization. Now, cognitive disorganization is part of psychosis, but it tends to be, for people with perinatal psychosis, significantly more prominent. So it's something that is a good thing to look out for this population. Um, the other thing that tends to distinguish perinatal psychosis from, say, other mental health concerns or psychosis that arises for other reasons is the course of illness. So perinatal psychosis comes on extremely quickly. Again, I'm going to switch terminology and refer to this as postpartum psychosis because this is where the vast majority of the research is done. And for postpartum psychosis, because it seems to be its own sort of thing, it seems to be extremely vulnerable to hormonal changes. It is responding, or it's coming about specifically because of the hormonal changes associated with giving birth that start with labor and delivery and obviously continue into the postpartum period. And the onset is very quick. It follows that exactly. Like we see people very often, even during labor and delivery, start to experience symptoms. Most often, people who have and go on to develop postpartum psychosis will start to experience symptoms within the first 72 hours. And almost all cases of postpartum psychosis, symptoms have started within the first 3 weeks after delivery. That might not be full psychotic symptoms that have started in that time. That might be prodromal symptoms, which we'll talk about here shortly, but symptoms have begun. We could identify that the person was already starting to struggle as quickly as 72 hours after birth. The onset can seem to be abrupt, or can seem to develop more gradually. I will say the reason I put this on here is because I think a lot of times people focus really heavily on the fact that it seems to be a pretty abrupt thing, like all of a sudden, you're 72 hours out from labor and delivery and you're having these symptoms. But it's really the observer that determines what seems abrupt or what seems gradual. And I have had families who will say it didn't seem abrupt, like it seemed like, over the course of several days or weeks that the person got worse and worse. So just keep that in mind. I think overall we could identify that for most people it's going to be abrupt, but it can seem to develop gradually because the symptoms can progress kind of insidiously. There's also tends to be a waxing and waning of symptoms. So that means the symptoms change in severity hour to hour, day to day. And I would say even most often like hour to hour. This is a very common feature of delirium, and Dr. Spinelli has talked a lot about in her research how there's an overlap of perinatal psychosis and delirium. This is where that happens. We see this waxing and waning of symptoms to the point where like people can seem relatively normal, right? Like they can seem like they're doing okay in the daytime, and then at nighttime seem like they're doing significantly worse or have a worsening of their symptoms. I have had patients myself I have sent to emergency because of psychosis symptoms that by the time they get to the emergency department, their symptoms have waned enough and that they're not as easily identifiable. And because they've waned, the person is more able to hide their symptoms, which is another problem because, once somebody comes out of psychosis a little bit, they can identify that some of the ways that they were thinking didn't make sense. And so they tend to hide that kind of stuff. Most people who experience psychosis do in the course of perinatal psychosis do return to normal, right? They return to baseline. Obviously, the quicker they return to baseline, the better the long-term outcome. There's good reason to get people help fast for other reasons, but that's another one, is that the faster we can get them back to baseline, the better long-term prognosis they have. But more than half of people will go on to have non-perinatal episodes of a mood disorder. So for most people, they will not just have a single postpartum psychosis episode. They will go on to have a diagnosis of an actual mood disorder, like a bipolar disorder. Some people do end up with something called encapsulation, which is where basically they seem to recover otherwise, but they hold on to some elements of some of the delusions that they had. This is pretty rare, but something to note that can happen. This is just a good slide to show you a little bit about, kind of the course, and this demonstrates sort of what we were talking about with most people do not just have an isolated postpartum psychosis episode. Most people have lifelong psychiatric disorder beyond that. Okay, so I mentioned earlier that the symptoms come on quite quickly, but those could be prodromal symptoms. So these are the kinds of symptoms that I want you guys to be able to recognize. I honestly would prefer that you can recognize prodromal symptoms than recognize symptoms of psychosis. Usually, one, psychosis is much more easily able to be recognized because it's pretty prominent. But two, ideally, we can intervene in the prodrome, right? We can intervene before somebody goes on to develop a full psychotic episode and get them the care that they need so that we don't have that problem. The prodrome is the period during which the person is experiencing changes in emotions, thought, perceptions, and behavior, but has not started developing or experiencing clear psychotic symptoms like hallucinations, delusions, or other symptoms of thought disorder, which we'll talk about in the next slide. Prodromal symptoms include changes in affect, which can be mood swings, changes in mood like depression or mania, feelings of vague suspiciousness that's not quite reaching the level of paranoia, irritability, things like that. Changes in thinking. Very often, people who go on to develop psychosis will talk about changes in their cognition, like difficulty with concentration and memory. The distractibility we talked about with mania is pretty prominent. Racing thoughts, again, goes along with mania. Odd ideas, people tend to think more unusually when they're going on to develop psychosis, and feeling like they're in a fog. People also tend to experience changes in their sense of self, others, or the world. So they feel like they're somehow different or that things in their environment are different. Very often, people who go on to develop postpartum psychosis will talk about having felt like they were in a trance-like state prior to that full psychosis setting in. And they can also experience physical and perceptual changes. Sleep disturbances being by far the most common, because again, that's going to be related to like the mood symptoms that we see initially, like the manic symptoms, somebody not sleeping as much but not missing it. They can also have more physical complaints. And they can have perceptual aberrations, which would be things like illusions. And illusions are different from hallucinations in that what illusions are is an actual distortion of something in your environment. So, for example, you look at the wall and the wall seems wavy, right? Or lights seem to have glowing of different colors, right? The wall is there and the light is there, but your perception of it is altered and distorted. A hallucination, on the other hand, as we'll talk about, is like your brain has specifically made something up. It is not in your environment and it's not being distorted. It's just like a totally made up thing from your brain. Symptoms of psychosis include delusions, which are false, firmly held beliefs. They can include things like persecutory delusions, which are paranoid delusions typically, religious delusions, delusions of grandiosity, people believing like they're the president, for example. These are quite prominent typically with people who have postpartum psychosis. They usually have pretty notable delusions. One thing I'll say about delusions is that people are, if their psychosis is not severe enough, are often able to tell that other people don't think the same way that they do, right? That their falsely held firm beliefs may not be shared by other people. And so they may not be willing to share that with you. The way we get around that is talk to the person as long as we can. So the longer you talk to somebody, if they are having a delusion, the more likely it is that they will express that delusion to you. Because it's so firmly held and so ingrained in like the way that they're thinking that it'll come out at some point. Typically. Hallucinations are, again, these false sensory experiences without stimuli being present. So this is an actual auditory experience, for example, of a voice talking to a person, or visually experiencing seeing a person in the corner or snakes on the floor, or things like that. In perinatal psychosis, there is a higher incidence of other types of hallucinations like tactile, olfactory, and gustatory, but those are still less common than auditory or visual hallucinations. Very importantly, auditory hallucinations can become command hallucinations. When command hallucinations are present, that's extremely, extremely dangerous. Command hallucinations are literally the voice commanding the person to act. And I will tell you, very often the command is not to pick flowers, right? Very often the command is to do something harmful. That's not always the case, but very often is the case. And so when command hallucinations are present, that's extremely risky situation. And it's usually only a matter of time until the person feels like they need to act on those commands. Disorganized thinking and disorganized behavior. So this is in that cluster, that symptom triad cluster. This is where perinatal psychosis really, really stands out. People who have perinatal psychosis will seem to be much more disorganized than maybe their counterparts with psychosis for other reasons. So this is not necessarily the mom who like puts the keys away in the refrigerator one time. This is like a pattern of behavior of like they cannot keep their life organized. They're putting keys away in the refrigerator all the time and the milk is going in the sock drawer. And also they're thinking really disorganized. Like what they're saying doesn't make a whole lot of sense. They're being really tangential or circumstantial. They seem really odd. They're dressing oddly. They're talking oddly. They're being unpredictable in their behavior. And what I would say, and this is how I educate patients about this too, is if nothing else, what will stand out is the oddness. Okay. So when somebody is very disorganized, how a lay person would see that, so like a family member, is odd. They would see that as like this person is just unlike themselves. They're just not behaving right. They're just something is weird, something is off, right? Something is odd. And I think that's a really good way of getting people out of the mindset that they need to like identify every single little, symptom and just recognizing like if something seems wrong, I'm going to get help because something is off, something is odd. This doesn't sound right to me. And then we need help. Okay. Okay. Let's see. All right. So last couple slides here. We've talked about how people with psychosis are at very high risk of acting on, for example, suicidal thoughts or homicidal thoughts. I do want to distinguish that from a very, very common mental health concern that arises for many people with depression and anxiety in the perinatal period, which is intrusive thoughts. I think it's something like 80+% of people who have postpartum depression or anxiety have intrusive thoughts. These are not the same safety concern that, for example, thoughts of harm to somebody else or themselves of somebody experiencing psychosis would be. So a couple of ways we distinguish that are, one, somebody who's experiencing intrusive thoughts of harm coming to themselves or baby typically has a lot of guilt and shame about those thoughts. Okay, so they feel like really disturbed by them. They feel guilty about even having those thoughts. They feel shameful about having those thoughts. Compared to somebody who has those kinds of thoughts but is psychotic, that person typically it aligns with whatever delusion they're experiencing. So they don't feel that same guilt or shame. They feel like this makes sense, right? These thoughts are a direct result of the things that they otherwise feel or believe. That's also another way of saying that they are ego-syntonic. So when something is in line with how we perceive the world or what we feel about the world, it's ego-syntonic versus intrusive thoughts, which are ego-dystonic. They do not align with the way that the person thinks or feels. Now, obviously, somebody who's psychotic, like in their normal everyday lives, this would not be ego-syntonic, but because of their delusions, it becomes ego-syntonic. People who are experiencing intrusive thoughts do a lot of things to avoid or minimize the risk of that thought coming true or triggers for that thought happening in their brain. Versus somebody who is having these kinds of thoughts but is psychotic, that person is not doing anything typically to avoid or minimize the risk of these thoughts because, again, they make sense to them. They're in line with whatever delusions they're experiencing and the overall disorganization of their brain because of the psychosis. And a good example of that is like the mom who has an intrusive thought of pushing the stroller into traffic when she's taking a walk. That mom is gripping that stroller, I can guarantee you, as tight as she possibly can. She's walking straight home. She's like decided to abandon the rest of the walk. She's going as fast as she can to get to a safe place. And you will have to pry her fingers off of that stroller because of that intrusive thought, right? Pretty much. Again, versus the parent who is experiencing psychosis, who just doesn't have the same logical disconnect from that thought. And so they're not trying to avoid or minimize that risk. Importantly, for somebody with intrusive thoughts, that thought does not equal action. They are not the same safety risk that somebody with perinatal psychosis is. All right. So some final things for us to consider. First, just as a recall, bipolar disorder is significant because of its heightened safety risk. People with bipolar disorder are extremely vulnerable to the hormonal influence of pregnancy and postpartum, so their illness is very likely to worsen. So even if they don't get psychotic, they are more likely to experience other safety concerns like those high-risk behaviors that are associated with mania or suicidal ideation that can be associated with depression. Perinatal psychosis is a psychiatric crisis. I've just detailed for you the really severe safety concerns that can come up with psychosis. Somebody experiencing psychosis in the perinatal period is in psychiatric crisis and they need a crisis intervention. We really want to identify signs as early as possible, and we can do that as early as in labor and delivery and on the postpartum unit, right? We have the opportunity to identify these folks who are going to go on to develop either, substantial bipolar mood episodes or postpartum psychosis, even as early as while they're still recovering from labor and delivery or during labor and delivery sometimes. It's important to remember the biological underpinnings of bipolar illness and perinatal psychosis. This is something that needs medical intervention. That is not to say that long-term therapy is not helpful. It's especially helpful for like processing the traumatic experience that is perinatal psychosis. It's helpful for people with bipolar disorder to do other things like to help them manage their illness overall. But people with these illnesses need medical treatment. Sleep is a very important tool for prevention of the severe consequences of these mood episodes, like the postpartum psychosis. And I think that has implications for the way that we tend to address sleep in the hospital systems. There's a lot of things that are wonderful about baby-friendly health systems and the baby-friendly mission, but one of the things that has come out of that is rooming in, which for somebody who's not vulnerable is great, but for somebody who is vulnerable, I often encourage my patients to send their babies to the nursery so they can get some sleep. And in general, I think we need to be thinking more about how to protect sleep for people who are vulnerable during the labor and delivery and the early postpartum. Also considering like how we equip patients and their families with the tools to seek appropriate help. Like how do we help them identify other types of mental health concerns? We talk a lot, fortunately, today about things like depression and anxiety and things like that. But how can we help them identify signs of mania or hypomania? How can we help them identify the oddness of psychosis if it's going to develop, that kind of thing? And then finally, another consideration I always think about is like how the baby feeding choices impact like the risk here. So breastfeeding, for example, is potentially a huge impact to sleep. And for somebody with bipolar disorder, that might be the difference between getting really substantial increased risk for mood episodes or even potentially psychosis and not. And that's not to say that we can't support lactation and all kinds of baby feeding choices for people with these disorders, but we just need to be more mindful about it. And I also would love to hear from you all. Like now that you know a little bit more about these conditions, what are some things that you think about in the settings that you work in? Like what are some things that now seem like they're implications for how we're going to care for people in your settings?
Feel free to come off mute and share if you have a comment or a question. While everyone is getting that ready, I know we do have one question in the chat, and I'll read that. It says, I often see clients who, after multiple pregnancies, have had a hysterectomy or tubal ligation and ask about risks related to hormonal changes from those procedures. Does having a procedure like this after a birth increase risk for psychosis as well?
Well, I can't say no and I can't say yes because we don't have any research on it. But what I can say is that we do know that hormonal changes like menopause also are important for people with bipolar disorder. So while the hormonal changes might not potentially lead to increased risk for psychosis, they very well could lead to an exacerbation of the overall mood episodes. And again, psychosis is a state that can exist in severe mood episodes of any kind. So there's theoretically an increased risk there, although I don't know what the statistics on that would be because we don't have the data on it.
Any other questions or comments for Dr. Reichenbacker? Okay, well, thank you all again for coming. I am going to keep my words short because, as you can see, I'm losing my voice. But I do appreciate you being here today. The recording will be on our YouTube channel. Feel free to rewatch or share. And the next series again will be in January, so no webinars in December. Have a happy Thanksgiving and take care.